We are 25 years into the opiate epidemic, and now we are in this last stage, which is the fentanyl era. And deaths are still hovering around 100,000. And although there has been a recent slight decline in this, what they call the fourth wave of the epidemic, researchers haven't quite teased out why there has been this decline. They attribute this potentially to the fact that more users are smoking versus using needles, and this has caused a reduction in the overdose rate. I happen to agree. If this is true, that means after 25, 20, 30 years in the opiate epidemic, all of our public health measures, our public policy measures really didn't make much of a dent. We've done better with such complex things as HIV in a shorter period of time, and many, many other disease states, and many chronic diseases as well. So what's going on here? Well, I'm going to introduce in this talk what can be considered a revolutionary concept in American addiction treatment, a concept that is, in fact, taboo. It is taboo in the culture of substance abuse and treatment, in our society and its perception of substance abuse and treatment, in the way those that suffer from addiction perceive the disease or the issue. It's taboo at all levels, including the medical approach and not so medical approach that still persists to this day extensively in substance abuse treatment. The concept I'm going to introduce is taboo. And yet, if we are able to grasp onto this very validated and evidence-based concept, we can achieve quite a bit. We can achieve better treatment modalities in substance abuse, including medication-assisted treatment, and we will be using opiate addiction as our main model. And we can have better policy, better social attitudes, and decrease this stigma. So let's get started. I'm Dr. B, and this is Dr. B 360, and the discussion today is the era of fentanyl, the concept of euphoria as described here, and methadone. We can learn a little bit about all of these things and have a better understanding of addiction, what it is, how it's couched in our social infrastructure, and the treatments that we dish out. We will do a quick tour of the horizon, if you will, of the recent history and events in addiction and the opiate epidemic, as well as review what I have recently discussed in my last few videos that have been sort of leaning towards this topic. So let's take a look. Let's take a look from a 30,000 let's get a bird's eye view of addiction over the last 25, 30 years. And take a look here. Let's begin with this graph here. Okay, and what we have here is what they call the four waves of the addiction opiate epidemic. Okay, and what we have is the overdose deaths, and it started in the 90s, and at that time, it was prescription opiate overdoses for the most part, and many people really don't realize that, but prescription opiates were causing overdoses well into the 2000s. And the idea here, and the reason they're calling it four waves, as you can see, there's four peaks here. Overdose deaths were going up, and at that time it was mainly prescription opiates. As they start to come down, people started to use heroin, which is the second wave. Okay, and this is a 2010 era, and it kind of peaked here, 2011, 2012. Right around here is when fentanyl started to come into the picture more and more so, and the heroin overdoses started to go down. And the real big spike in the epidemic is with the introduction of fully synthetic opiates, being fentanyl, extremely potent, extremely addicting, and very dangerous because it doesn't take much for you to overdose. And this is the part that I'm very much concerned about, from here on. And this started to slightly go down, and you have the fourth wave, which is actually, nowadays you really can't call it opiate overdose deaths, because almost everybody, what they are getting out there, it's polysubstances, but there's two things going on. One, you don't really have opiate addicts, you don't have methamphetamine addicts or stimulant addicts. Everybody is doing everything. That's one idea and one fact. And the other part of this is the fentanyl out there, or the methamphetamines out there, whatever it is, mainly the fentanyl or the opiates, they're just so cut up and with all kinds of stuff, and that starts to show up in the post-mortem analysis of the fluids, and they have everything in it. So we're past this, and the question becomes, why can't we get control of this? There are many reasons, right? And they have just as much to do with education and prevention and the societal context in which addiction arises in, as much as they have to do with treatment. They're all interrelated, whether it's policy, whether it's attitudes, whether it's false beliefs about what addiction is and what's going on, all of it. Attitudes towards medication-assisted treatment. But I really just want to concentrate not on all of the societal issues, although what we're going to introduce really touches on that as well. So that's a little background and history. The other piece that I want to bring into this background and history is recent videos that I have made. My most recent one discussed the concept of euphoria. I gave a little historical account of what euphoria has meant, all the way back to the Greek meaning of euphoria, and the fact that euphoria was always a positive thing. It meant a sense of well-being. And its introduction into medicine, maybe 1700s, 1600s, whenever it was. And at that time, it was sort of used in the medical profession to describe patients that were getting better from whatever disease or issue that they had. And it was a convalescent stage, and it was used as a positive clinical term. And 18th, 19th, and obviously 20th century, it became extremely pathologized and affiliated, not as a diagnosis, but as a part of the symptom complex of whether it was opiate abuse, frontal lobe lesions, all kinds of stuff. Euphoria got a negative rap, and I think that has been extremely harmful, both in the way you view the addict, someone who's having a good time or feels good or just wants to feel good. But also the fact that if we looked at this term appropriately, we can take advantage of it and utilize it, in particular, uh, an opiate addiction treatment, but also in other substances that are abused and need treatment, whether it's stimulants, alcohol, benzos, even, and otherwise. So that's our starting point. And why did fentanyl really antagonize this issue of euphoria and really brings it to mind? Well, let's move on. Let's take a look at a couple of other things. You know, the numbers are really no joke, right? You know, when you look at the prescription uh, uh, opiate era, you know, it was 16,000 deaths per year, 33,000 deaths per year during the heroin epidemic. And then, you know, we got well over 100,000 a year in the synthetic opiate or fentanyl era. And then it recently decreased a little bit. And we are in the fourth wave, which is polypharmacy. And here's another graph that it's the kind of the it tells you the same thing, but some milestones during this recent history. Okay, it was really not termed an epidemic in the 90s, right? And you know, people started getting the wind of it in the 2000s, and it was sort of officially declared an epidemic 2010, 2011, when we hit 33,000 deaths. And you know, it was all hands on deck moving forward from then. And even this number is bizarre, where it went from 33,000 to 100,000 deaths per year, and it's still lingering way up there. It doesn't make sense. A public health issue that doesn't need necessarily any bench science to get an answer to, yet this is where we are. Sure, we can talk about bench science and coming up with medication that stop addiction, but addiction and substance abuse is an extremely complex disease process, and it's deeply interwoven into our society, into our culture, into who we are, how we live, and how we interpret the world, our sense of meaning, our view of ourselves and those around us. This makes it quite a bit more complex in some ways, but in some other ways, it really is a great window of reflection into the extent of pathology in our society and what we need to do to fix everything as a whole, which would really spit out better substance abuse and addiction outcomes. Incidentally, as I told medication assisted treatment as sort of the pinnacle of opiate abuse, at least treatment. Here we are 25, 30 years later into this epidemic and in the 21st century. And I still see significant, bizarre stigma towards not only the user of drugs and opiates, but the treatment that could save thousands and thousands of lives. But it almost seems like it hasn't had much impact since the fentanyl epidemic. Reasons are complex, but there's a piece of it here that I think would really benefit us, and we could really bring this thing to considerable halt. Let's take a look here some more. What do we have? As I described in previous videos, and I'll be a little bit more brief about it here, you know, I sort of described the issue with fentanyl is the following. Your 0 to 60, and zeros from when you take the drug in, and we'll call 60 the nodding off zone. In between that, there is a Goldilocks zone that someone who uses opiates sort of aspires to get to, right? And with fentanyl, they zip right past that Goldilocks zone. And it's okay to call that the euphoric Goldilocks zone, right? Yet, conversely, in some senses, so what I'm saying here is that fentanyl has a horrendous euphoric Goldilocks zone area. And I'm going to call this the euphoric index of the drug. But it's highly addictive. Why? It's extremely potent. And what do we mean by that? Is it because it feels so good? No. It takes an extremely small amount to fill up your receptors. It's extremely short acting, that by clinical definition, theoretical, but for the most part, true as far as we know. The shorter acting the drug is, it's much easier to create the framework of addiction within your central nervous system. It's short acting and it's potent, okay? And so you create a lot more susceptibility to deeply ingrained physiological dependence and the need for constant redosing. And when you stop, people get sick really quick. It's a very powerful drug. But nevertheless, and we're going to call that Goldilocks zone Euphoria, and I'll just give it away at this time, and I'll pull this up for you right now. We'll call that the euphoric index, right? And this is something that we'll have to get worked out in much more detail by constructive studies, but nevertheless, we'll call it the euphoric index. And what I'm saying here is, it's not on here, but I would put the euphoric index, for example, of fentanyl at about 5 or 6, and that would be right here, right? 5 or 6. Now, it's interesting you're saying, whoa, you have heroin down here and Suboxone here. Okay, I'm not talking about how powerful it is or how addicting it is. I'm talking about a particular component of it that drives the addiction, but it's that pleasure state, that euphoria, that original reason that somebody may have gone to the drug. Because if you ask 9 out of 10 addicts, what would you prefer to be doing, or which is a better high, heroin or fentanyl? And when they think about it, they would tell you heroin's much better. And compared to fentanyl, heroin from 0 to 60, 0 to the not off zone, it is, you get the drug in, and then there's a period of time, and it's enough time for them to pursue the drug consistently and repeatedly, where they're in that euphoric zone, and then they get to the not off zone, and that not off zone is very different than the not off zone of fentanyl, which is frightening and scary and almost goodbye. And with heroin, you can see that you can sort of wake people up, okay? And, if I was going to, keep in mind, our fentanyl, which would be right here between the green and the blue, and I would give it a 5 or a 6, the fentanyl is much more potent and addicting, right, than heroin. I'm sorry, than Suboxone or even heroin, right? But we're not talking about addiction potential here. We're talking about euphoric index. And so if that makes sense, and if I was going to line these up, I would say Suboxone has the crappiest euphoric index, but it does do something else pretty well. It fills the receptors, stops cravings and withdrawal. The euphoria, this what I would call the supertentorial addiction property of these drugs, is slightly above wherever that craving is. So you have Suboxone, you have fentanyl, right here. And what is better than fentanyl in terms of euphoria? Well, I would say, I'm sure there are others, but for our purposes and what most people would be familiar with is methadone. Again, methadone is a good drug in terms of taking care of cravings and withdrawal, and it has better euphoria than Suboxone, right? And from there, you can even go to long-acting morphine, and we'll leave heroin at the pinnacle of euphoria. Might be a little bit different for this person or that person, but this is meant as an illustration. Here's what we're trying to get at. People fail in terms of in terms of their ability to stay on Suboxone in the age of fentanyl, right? Because fentanyl is so addictive and so powerful, even if you can get the receptors filled, something is missing. And it just happens that if you can fill that euphoric index to some extent, you can overcome relapse. Number two, with fentanyl, the initial withdrawals that you have to be able to tolerate to get on Suboxone, because of the fact that it's an agonist and antagonist and you can't take it too early, it's a lot more difficult for them to bear. It's extremely potent. Those two things make getting on Suboxone and staying on Suboxone much more difficult. And so this is where methadone comes into play, because it actually has a higher, a little bit better euphoric index than fentanyl, and obviously less deadly and long acting, and it's used as part of our arsenal in medication assisted treatment. And for this reason, I advocate something a little bit different than I've always advocated. I've always been a big fan of methadone and Suboxone, but for years my position was, well, nowadays you should get on Suboxone first, or try that. Once that fails, you move on to methadone. It's a heavier drug. It's a full agonist. You can easily overdose on it. You can take other agonists with it. So, it has a lot of negative things that I always felt Suboxone was the first go-to attempt at medication-assisted treatment, and much less people probably needed to be on methadone. And in addition to that, in this country, it comes with many barriers to access of going to treatment, having to potentially pick it up every day, and so on and so on. So I thought, a lot more people could and should probably be on Suboxone. But since we are in the age of fentanyl, I think methadone has upped its value as a resource of medication-assisted treatment to be able to get people off of fentanyl and on to medication-assisted treatment. Why? uh, simply because it really has what I call euphoric index, much more of a euphoric index than fentanyl, right? And certainly much more than Suboxone. Okay, this brings something else into prominence of thought, and as I've laid it out here, I've explained that there's this component of addiction, right? And it's that euphoria component in addiction treatment. Whether it's a 12-step facility, which most still are, or medication assisted treatment with full on medical clinicians, you're not allowed to wonder about someone's euphoria. It's not part of your note taking and description, even of someone's addiction, abuse, potential liability, all of that stuff. And yet, it's a critical factor in why someone even may become addicted in the first place, or what's keeping them on the drug. But it just happens that since fentanyl came in and it has these other components, because addiction is quite complex, right? Even if we're talking about the physiological level or the central nervous system level without discussing the environmental influences and what makes addiction. Just at that very intimate level of physiology, pharmacology, and psychology, the frontal cortex, right? Fentanyl is highly potent and addicting and powerful, but it sucks in terms of its euphoria, right? And I've suggested that methadone nowadays really should play a much more prominent role as people fail to either be able to get on Suboxone or stay on Suboxone and go back to fentanyl. Incidentally, people couldn't even do heroin if they wanted to because it's not out there, right? The market's completely been, replaced with fentanyl. And these are additional factors that I'm not bringing into the discussion. I want to keep it very focused on this part of it. But this brings in the additional component of this as we're talking about the euphoric index, which I think American addiction treatment and medication assisted treatment discussion needs to include. Because if you included it, not only would you see the value of methadone, which is readily available for the addict, you might loosen the laws where it could be dispensed in an office, which is what they do in the rest of the world. But that's where you start looking at the full arsenal of what should be medication assisted treatment. Long-acting morphines, synthetic pharmaceutical grade heroin. I'm not just making this up. These things have all been done in different shapes, ways, and forms across the planet and are being experimented with and discussed, and studies done on them all across the planet. As a substance abuse treatment doctor, I'd like to have more than one option to treat opiate addiction. And if I have access, I used to run a methadone clinic as well. But, in my medical office, which is just a substance abuse and polypharmacy medical office, what's my choices? Suboxone. And I see people fail every day, depending on where they are in their fentanyl addiction. I see them fail on Suboxone. And there's 10 different ways to skin this cat if one had the full arsenal at my disposal. Methadone, long-acting, morphine, pills, and heroin. That's not a reality today, but I'm hoping that those of you that have been following me and following this line of thought really get a sense of what I'm talking about here. Pass this video on in the most ideal situation. I'd like to see advocacy at the policy level so that our hands are somewhat untied. Why? Because we can, just in this one area, we can extensively, to a great extent, reverse the overdose deaths of this tragic epidemic. This topic is much broader and deeper than what I have just simply presented here. The euphoric index, this should be a clinical entity, a clinical term. We should do quite a bit of research around it to really come up with some sort of a scale to be able to describe it as we pick and choose medication for our patients, to be able to make sure that we keep them off the streets, keep them off of illicit substances, keep them off of things that will kill them, give them infections, get them in jail, and destroy their lives. Think about it and leave your comments below. Thank you for watching. Don't forget to like and subscribe. And please, whether you agree with me or not, pass this talk on. I think this is one of the most important discussions in substance abuse treatment that has not really happened in this country, and the concepts most people are unfamiliar with. See you guys soon. Peace.